why are the heart patients, why do they get a more severe disease as compared to others? So remember right from the beginning that the chances to get the disease is the same for everyone. And that depends upon the prevention, social distancing, use of mask, and all other such parameters. So for a cardiac patient, chances to pick up the disease or get the disease is the same as all of us. However, once they have the COVID-19, cardiac patients have a higher, more intense level of the disease. And that is why the mortality rate is very, very high in it as well. So today we are going to talk about what are the reasons that this happens. So let's start. Good morning, guys. How are you doing? Thank you very much for joining. And let us start our discussion. So today we're going to talk about the cardiovascular system issues or patients and why the disease has a higher mortality in them. So I'm going to share my screen as usual. How are you? Welcome back. All right, so let's look at some of the basic numbers that are interesting for us. First of all, if you see here in China, so this is the data up to 11 February. And what they said was that the case fatality rate for cardiovascular patients is 10.5%. That means when the cardiovascular patients get COVID-19, their death rate is about 10.5%, which is a really high and scary number. Then there are other cases, for example, diabetes, chronic obstructive pulmonary disease, etc. And hypertension itself is 6%. So the case fatality rate for hypertension is 6%. So thank you very much, guys, for joining. Kristen, thank you. Thank you, guys. Welcome. And let's continue. Thank you very much for joining, Shelly from Indiana. Ahmed says, how are you? I'm doing good. So let's start. Very, very important topic today. So we're talking about the cardiovascular issues and the why do we have a higher case fatality rate or more morbidity and mortality in these patients. So I'm showing the epidemiological study data here, and that is that China has they had the highest mortality rate in the cardiovascular issue patients or cardiovascular patients, then about 6% in the hypertension. If you look at Italy, although the data is still being generated, but there was a study in Italy that was on 355 patients, and they found that 76% who died were hypertensive, and 33% who died were ischemic heart disease. Remember, Italy has the world's second most oldest population as well. So cardiovascular issues are more common in older population. So this is a very scary number for the people who died in Italy. There is a preprint of a study here in New York. So this is not yet peer reviewed, but let me show you that study. So here in New York, this is a study where they did a retrospective study. That means they looked back at the data, and they had a total of 5,700 patients that they looked at. And look at this. This is New York. Hypertension, 56.6% of the patients. The most common comorbidities: hypertension 56.6%, obesity 41.7%. Obesity is something that has been less reported from other countries. From the US, obesity is the second major cause. And then diabetes 33.8%. So this is a very scary situation. And of course, going back to this, that the cardiovascular patients, they tend to have a higher morbidity and mortality rate. The second thing that was interesting, again from New York, interesting, scary, is that patients who were between the age of 18 to 65, their mortality with the cardiovascular issues was 76.4%. And the patients who were greater than 65 years of age, their mortality was 97.2%. So very high. So keep this in mind, and now let us start our discussion. So first of all, what we are going to do is we are going to see the mechanism of the damage. What is really the reason for the damage? So here we are. Look, cardiovascular damage is actually very simply understandable. One reason is ACE inhibitor 1 and ACE inhibitor 2 enzyme imbalance. We know that we have ACE enzyme, I should call ACE1 enzyme, not ACE inhibitor, I'm sorry. ACE1 and ACE2 enzyme imbalance. And we will discuss that in detail today, that what are these enzymes, where are they present, and what is their function. Everyone who has been leaving comments on YouTube saying that ACE2 will not cause a change in angiotensin to cause vasodilatation, please stick around. We will look at that mechanism. So ACE1 and ACE2 receptor enzyme imbalance. So that is one reason. So you can call that as a dysregulation, that ACE1 is usually vasoconstricting agent, or it causes the angiotensin 2 production, which is a vasoconstrictor. ACE1 is also pro-inflammatory. ACE1 would also cause more things which are related to higher inflammation and higher blood pressures, for example, vasoconstriction as well. ACE2 is opposite to that. It is anti-inflammatory, it is vasodilator as well. So when the virus comes into our body, there is an imbalance between these two, and that causes the damage. The second cause of the damage or mechanism of the damage is that the ACE2 are present in the heart. ACE2 receptor. Remember, coronavirus loves to bind with the ACE2 receptor with its spike protein and enter into our cells. In one of the studies, they looked at the density or presence of the ACE2 receptors. And if you look at that study here, ACE2 expression. So the study is ACE2 expression in human heart indicates new potential mechanism of heart injury. So in this one, what is really interesting is that this line is very interesting here. The expression of ACE2 in the heart is lower than that in the intestine and kidney, but higher than that in the lung, which serves as a main target organ for this virus, including a potential infection susceptibility of human heart. So heart has the expression of ACE2 enzyme more than the lung. So just the presence of this enzyme in there would mean that the virus can actually come and damage the heart as well. So I'm looking at the chat here. Thank you. Thank you. One of the best live streams. Greetings from Vienna. Greeting back to you as well. We all are here. Excellent. Assalam alaikum assalam. Welcome everyone. Great to have you here. An honest doctor, a smart doctor. It is almost miracle. Thank you very much. Thank you very much. Thank you for the kind wishes and prayers. So back here, the ACE2 are present in the heart as well. Then there is an indirect damage to the cardiovascular system when the lungs become sick and there is less oxygen. Of course, we know that the heart will be the first organ with the kidney to start getting damaged. Correct? Do you know why the heart becomes damaged so quickly in the less oxygenation? So that is, Ahmed, that's a very good question. And I think it is something to do with the temperature, BCG, HCQ, and many other things. And I have done a discussion about that beforehand. Hello from Saudi Arabia. Takayama, hello, back to you as well. Big fan. Thank you very much, Krishna. So back here to the discussion. Sorry, I'm striking a balance between the two channels here. The indirect damage to the heart. Remember this, that heart. So if I draw a heart here quickly. So let's say this is a heart. We know that the heart, when the coronary arteries, so let's say this is the aorta, from the aorta, coronary arteries emerge. You know this very clearly, that all the oxygen present in the blood that is coming into the coronary arteries, heart extracts 100% of that oxygen. So heart does not say that, all right, you know what, out of the chunk of blood, if you give me this much blood, I'm only going to take 25% oxygen from it. And if you give me less blood or less oxygen, I am still okay. That is not the case. From a milliliter of the blood, excuse me, heart will extract 100% oxygen. That means if for some reason you reduced the amount of oxygen in a specific amount of blood, then the heart would be damaged. Heart will be ischemic. So the very first thing to keep to the lack of reduction of oxygen because lungs are sick. Finally, the fourth mechanism that causes the damage is antiviral drugs themselves. Many of the antiviral drugs cause arrhythmias and heart failure. They precipitate heart failure. And if a patient is already in the heart failure, they can aggravate that situation. So keep these four mechanisms in your mind. So I'm going to repeat them. Number one, there is an imbalance of ACE1 and ACE2 enzymes, which means a pro-inflammatory versus anti-inflammatory system imbalance. That secondly, there is the presence of ACE2 receptors in the heart and almost more density than the lungs, so heart becomes a target as well. Thirdly, when the lungs are damaged and the oxygenation of the body drops because the lungs are sick, that would start damaging heart as well. And fourthly, when we start treating the patient and we start giving antiviral drugs, that in itself causes the damage too. So these are the four mechanisms. Now, let us look at what are the outcomes of these mechanisms. What really happens? So number one, ACE2 enzyme dysregulation. I'm using the word dysregulation because some studies show that ACE2 expression will increase and some studies show that ACE2 expression will reduce. And as I was reading one study today for this lecture, and in which they were talking about maybe some visceras have more ACE2 and others have less ACE2, and maybe there is an imbalance. And so I thought that we should use the word dysregulation instead of regulation. Here is that study. This article here, I think it's not a study. This article here discusses the ACE2. The point of this article was that they were trying to answer the question that should the people stop taking ACE inhibitors or angiotensin receptor blockers. So in that article, they discussed the ACE2 in detail, and for every point, they keep saying that, hey, it is possible that the ACE2 are increased, or it is possible that they are reduced. We're not sure yet. So I actually then just took that much, that there is a dysregulation of the ACE2 receptors. I keep saying ACE2 receptors, ACE2 enzyme. Then there is acute coronary syndrome that can be triggered. Again, that can be triggered for two reasons. One is that the virus itself can damage the coronary vessel. And secondly, because of the lung damage and hypoxia, that in turn would cause the coronary syndrome and hypoxemia and then ischemia of the coronary artery. Then there is myocarditis. This is very, very important. So heart, if I make a heart cell again, so let's say this is heart, not cell, but the heart tissue. We know that a heart tissue is comprised of muscle, that is the myocardium. Myocardium, that is a muscle. And then it has an outer covering around it like a shopping bag, and that is the pericardium. and then it has an inner layer which is facing the blood, and that is the endocardium. So this muscle, the myocardium, can become infected and damaged. So here, I was listening to a doctor from Mayo Clinic, and he was saying that, hey, we are observing two kinds of damages. In the older age, we are seeing that the muscle of the heart is becoming damaged because of the cytokine storm. Remember, I did a discussion that why does SARS-CoV kill that fast? And I discussed about the cytokine storm and the heavily inflammatory response of our body to the SARS-CoV. So in older people, cytokine storm seems to be causing damage to the cardiac muscle. In the younger people, there is a primary effect of the virus, that is a virus itself going into the heart using the ACE2 receptors or ACE2 enzyme and then going in and causing the damage. Of course, that does mean that there can be direct damage to the older population's heart as well. It's not that they cannot be directly damaged by it, but they are more prone to the cytokine storm. Then the heart damage itself is because of, as we just discussed, reduced oxygen and ACE2. And we have discussed this in the past as well. We'll discuss this again today. ACE2 is not only going to convert the angiotensin into a vasodilator. I'm saying dilator. ACE2's function is to convert molecule into angiotensin 1 to 7, which is dilator. It is ACE1 whose job is to convert angiotensin 1 into angiotensin 2, which is a vasoconstrictor. So, plus the ACE2 are anti-inflammatory as well. So these are the outcomes. Because of these outcomes, patient is going to develop severe cardiac damage. And as soon as the patient has a cardiac damage and heart failure starts or exaggerates, if the patient already has it, then all bets are off. It is very difficult to bring the patient back from there. So, Kahina, that seems to be the lung damage in a lot of patients, of course. So we'll talk about the hypercoagulability tomorrow. So yes, there is blood clotting as well. We should factor that into the whole situation as well, which can precipitate acute coronary syndrome. So you are very, very correct. So hi from Iraq, hi back from US. Acoustic theory, the choice was between clotting and the heart of this lecture, and we wanted to hear the cardiac lecture. So here I am with the cardiac lecture. We'll talk about the coagulability tomorrow. Yes. So acoustic theory, I had already heard you, and we would do that tomorrow. All right. So back to the cardiac. So now we know the reasons for the cardiac damage, these 4 reasons, the outcome of the damage, and now let's also see what will happen in long term. So there is an acute damage, and let's say the patient survives. Is there a possibility that there is a long-term issue for the cardiac system as well? So let's look at that too. So this study is not for COVID-19 or SARS-CoV-2. This study was done on SARS-CoV, that is SARS-CoV-1, 2002 to 2005. In that study, they followed up people after 12 years, and they found out that the people had hyperlipidemia, 68% of them, cardiovascular abnormalities, 44% of them, and glucose metabolism issues, 60% of them, compared to those of the same age who did not have exposure to this virus. And again, that is coronavirus SARS-CoV, not SARS-CoV-2. So maybe SARS-CoV-2 will not do that. But if we take SARS-CoV as an example, we may end up with people who may have long-term lung damage and heart damage and pancreatic damage resulting into the diabetic situations. So this virus may not just cause acute illness, but it may actually live with us for longer and continue to cause damage. So that is another thing I wanted us to be aware of, that there is a chronic damage, at least with the SARS-CoV. Now the reasons for death. So look, I discussed those before as well, but let me do this. Heart patients with the cardiac insufficiency. That means cardiac patients who do not have enough cardiac output, which means cardiac myopathies, which means cardiac hypertrophy, which means heart failure. So many such situations where, or valvular insufficiencies, where the heart is not able to pump enough blood out for the body. If such a patient becomes ill with COVID-19, imagine what would happen. One, the COVID-19 or the SARS-CoV-2 is directly going to attack the heart. Second, because of the infection and the disease of the lung, one, we have less oxygen. Secondly, we have more demand for oxygen because body wants more oxygen and nutrition to fight the infection. The result of this will be that the patient's heart failure would be exaggerated because of extra demand and inability to supply that demand. Why the inability to supply that demand? Because the heart is already in the failure. One. Second, heart is not getting enough oxygen. Two. Third, heart may be infected by the virus itself. Three. So all of those, and then fourth, the cytokines, the inflammatory proteins produced by the cytokine storm, they can be also doing a number on the heart. So cardiac insufficiency patients may end up with an exaggerated insufficiency that would create a vicious cycle and cause death. Then patients of acute coronary syndrome. So acute coronary syndrome are the patients who have angina, which is acute in nature. So their problem is that as soon as the infection comes in, COVID-19 comes in, mechanisms are the same once again. Less oxygen, diseased heart, diseased lung, increased demand for supply of oxygen, and the result will be that there will be acute cardiac reserve depletion, acute depletion of the cardiac reserve. What is happening in the coronary artery is that the coronary arteries are not able to supply enough oxygen for the heart to itself work correctly. Now, on that heart, if you put extra burden to say, Mr. Heart, you need to work more, heart is not going to work more. So the heart's reserves will be depleted and the sudden deterioration of the heart would occur. So if you're seeing that people with the cardiac issues with this virus very quickly move towards deterioration because their hearts cannot keep up. Number one. Number two, their hearts are not getting oxygen. Number three, they are getting infected. Then on top of that, if you start giving antiviral drugs, then the heart is it's a sitting duck. Then another reason in the old age is that our immune systems start deteriorating as we become older. Just like other tissues of the body, which we can even see that the skin and the other tissues are deteriorating, similarly, immune system deteriorates as well, which would cause a severe infection compared to younger people who may not have as severe an infection. So immune system weakness in older age is also a problem. And then, as I discussed before, antiviral drugs, when used in people with cardiac issues, then the cardiac insufficiency increases, then arrhythmias set in, and cardiac disorders, for example, myopathies can occur. So with this discussion, before I go to the ACE part of the lecture or the talk, I hope this is clear that there are four basic mechanisms for the rapid cardiac damage and highest mortality in the cardiac patients. And the four are ACE1 and 2 imbalance, ACE2's presence in the heart, ischemic injury to the heart because of the lung damage, and the drugs themselves, antiviral drugs. Does this make sense? So, Mary, your question directly affects the heart. Yeah, the studies that I'm seeing, they are saying that the ACE2 enzyme is present in the heart as well. Because of that, the virus can actually directly impact the heart too and cause myositis or cardiomyositis. So yes, and I was listening to a lecture this morning from a doctor from Mayo Clinic, and he was also saying that in the older patients, the damage to the heart is by the cytokine storm, and in the younger patients, the damage to the heart is a primary damage by the virus itself to the heart tissue. Okay, so let's continue our discussion. I want to now talk about a little more about the ACE inhibitors, ARBs. We've talked about them in the past as well. But this confusion, I continue to receive this message again and again in my comments that people come in and they say, you do not know what medicine is, and ACE2 does not cause anything that would cause vasoconstriction. It does that would cause vasodilatation. It should be vasoconstriction and so on. So I wanted to make sure that we can look at it together. So look, let's say this is a cell, any cell. Cells can have, let's use lung or heart cells. Cells can have ACE1 on them, the endothelium of the lung. That means if this is a lung and we have a blood vessel in the lung, the blood vessel of the lung, the endothelium of the lung expresses ACE1 and ACE2. So let's say this is an endothelial cell, although they look different in their shape, but let's assume this is an endothelial cell. It has an ACE1 receptor. The study that I was discussing before, they have studied that if you block the ACE1 receptors by ACE inhibitors, somehow there is an upregulation of ACE2. Remember ACE2, we are talking about blocking ACE1 and talking about upregulating ACE2, which in turn, ACE2 upregulation can be good or bad. Why is it bad? Because the virus uses this enzyme as a receptor to get into the cell. Good because ACE2 are anti-inflammatory in their nature and they would help reduce the inflammation. Because of this, cardiologists have not been able to come to a conclusion to say that patients who are using ACE inhibitors or ARBs should stop doing it because there is a possibility that these are actually helping, or there is a possibility that they may be not helping. So there is not sufficient studies. So American College of Cardiology simply says do not make any changes. Even this study that I showed you here, this study, if you go to the end of it and look at their conclusion is once again that we do not think that you need to change anything. Somewhere over here. I'll put the link there for the conclusion. And you can see that they simply say that we don't feel comfortable that we have enough data to say stop using ACE inhibitors or ARBs. Okay, so continuing here. Let's say that we are using angiotensin receptor blockers or ACE inhibitors that causes the upregulation of ACE2 receptors or ACE2 enzyme. What that would now do is the coronavirus is going to become very happy. This guy is over here. He's happy because he has lots of ACE2 receptors to infect our cells and cause damage. That is the bad side. The good side is that the ACE2, when they are activated, what we end up with is we'll end up with more anti-inflammatory response, which is better. Now let's look at the ACE2 for a second. ACE2 are present in lungs, cardiac myocytes, cardiac fibroblasts, coronary epithelium. They are also present in kidney. They are also present in vessels. So they are present in lots of places, and of course, intestine and kidney. Actually, their ACE2's presence in the intestine and kidney is more than lung and heart. And this is why it is actually possible that there is an infection of the kidney as well. So there is a question. Sorry for asking again, my connection went down. How are those with hypertension affected? What blood pressures put you at risk? Is losartan okay to take? I read. So I can't directly provide an answer for a drug because I'm not your doctor. But what I'll do is we will talk about hypertension specifically tomorrow. So I think what we're going to do is tomorrow we're going to talk about hypertension, and day after we will talk about the hypercoagulability state. Because hypertension is connected to this topic as well, I would want to do that separately. So there is a question. Guy says, "Hi, with coronavirus surviving outside the body on surface with bacteria, wouldn't this also mean that virus is replicating?" Virus, I haven't heard this virus replicating inside the bacteria. And secondly, even if it is replicating on our surface, there are many other viruses that are sitting in there and replicating. That's fine. It is really when it enters our body and starts replicating there, and our immune system's response to that, that is what really matters. So there is a question here. Could the combination of experimental drugs, hydroxychloroquine, azithromycin, antivirus, killing more patients due to cardiotoxicity? So Puru, I'm going to give you a very simple answer. Yes, this is true that hydroxychloroquine, chloroquine, and azithromycin can all be cardiotoxic, but in therapeutic doses, hydroxychloroquine, I'm not talking about chloroquine, chloroquine can cause damage. In therapeutic doses, whichever doctor you want to talk with, for 10, 20 years of service, they have not seen a single patient of cardiotoxicity in therapeutic doses. So these drugs can cause, especially hydroxychloroquine, they can cause cardiotoxicity, they can cause retinal damage, and they can cause blood disorders. So these should not be taken without the prescription, and these should not be taken more than the dose that your body can handle, so that if taken in therapeutic doses, these are fine. Okay, back here. So angiotensin 1 and 2. So this is an important thing here, guys. First important top thing to keep in mind. ACE2 enzyme can convert angiotensin 1, and I'll talk about angiotensin 1 in a second, or angiotensin 2 into angiotensin 1 to 7. That is what it does. And this is where people keep yelling at me that why do you say that ACE2 would somehow create something that is vasodilator? They continue to think about angiotensin 2. Guys, ACE2 is a relatively new enzyme. I think it was found in 2000, so relatively new, that 20 years ago. This enzyme can pick up angiotensin 1 or angiotensin 2 and convert them into something called angiotensin 1 to 7. And the function of angiotensin 1 to 7 is, it is one, anti-inflammatory, it causes vasodilatation, and it is anti-apoptotic. Anti-apoptotic means that it stops a cell from dying. So having ACE2 enzyme on our cells is actually good because it causes the cell not to die. So let's look at it. This was a study done on SARS-CoV, not SARS-CoV-2, SARS-CoV. What they found was that the expression of the spike protein causes loss of ACE2. And so as you study various studies, you would see that there is lots of controversy out there, or lots of conflicting, contrasting studies. Some studies say I did this and ACE2 were increased. Some say I did that and ACE2 were decreased. So it is possible that there is a dysregulation. Sometimes ACE2 and in some viscera ACE2 increase, and in some viscera they reduce. In SARS-CoV study, they found out that the spike protein, which is present on SARS-CoV-2 as well, causes the loss of ACE2, which then, so look, ACE2 is anti-inflammatory. So when ACE2 is not present, the things that are inflammatory would start. So neutrophils will increase. These are inflammatory cells. Vascular permeability would increase because of the cytokine, because of the inflammation. And then pulmonary edema would occur, which is the acute respiratory distress syndrome starting, which would then convert into septic shock. So one of the reasons that is happening is lack of ACE2. Similarly, lack of ACE2 causes myocardial injury as well, by the same mechanism that there is lack of anti-inflammatory behavior. So can you see the problem now that being more will cause a damage because virus can use them and get into the cell and cause damage. ACE2 being less will cause a damage because they are anti-inflammatory and their absence would cause more inflammation, plus their absence would cause cells to easily die by apoptosis, and their absence would cause more vasoconstriction because they are helping with vasodilatation. All of those things are going to aggravate the cardiovascular system to the extreme and end up with the result is the death. Again, don't be keep the death part in context that the death rate is about 10% of the admitted patients. Or you have seen that the death rate is, sorry, let me take it back. Out of everyone who dies, 10% of them have cardiovascular issues. Okay, so now the last part of the discussion today, renin-angiotensin system and the ACE enzymes. And I'm doing this because I am challenged a lot by folks to say, why do you say that ACE2 causes vasodilatation? It should help cause vasoconstriction. So I want to quickly look into this together. So here is our kidney. Our kidney has about 1 billion nephrons or whatever. I think these are 1 billion each kidney. If there's a different number, whatever it is, it's a large number. Every nephron is the urine making unit. Every nephron has a blood vessel coming in called afferent arteriole, and then the blood vessel comes in, it becomes a big mesh of capillaries which are used to create urine, or the filtrate we call it. It's not urine yet. Urine would be when it is at the end of the nephron. So filtrate is created, and then that blood would go out through the efferent arteriole. The way I remember that the blood comes in through afferent is A for arrival, A for afferent. Afferent, A for arrival. And the other one is the other one, or you can also remember that E for ejection and E for efferent. Now, here is the deal. This is a fun thing. Every nephron has a renal urinary tube. So nephron has a part which is the ascending tube, and that tube has a dense part of the cells that are near this glomerular apparatus. This is called macula densa. Macula densa is the chemical system in our kidney with every nephron to look at urine's osmolality and then decide how to manage the electrolytes and water. So imagine that we have 2 billion chemists sitting in our body looking at our body fluids every single second to see, do we need to conserve electrolytes, or do we have more electrolytes or less electrolytes, or what should we do? Similarly, this blue thing, every afferent arteriole, which should be in billions as well, has a blood pressure cuff on it. We have 2 billion blood pressure apparatuses in our kidney. They release renin, or they convert prorenin to renin. Renin is a chemical substance which is present in our blood in the form of, in the form of prorenin. That renin will be released in the blood. So if I come down here, so look, kidney will release renin based on the blood pressure. Once the renin comes into the blood, our liver also makes another enzyme or another protein called angiotensinogen. So these blue guys are angiotensinogens. Renin coming from the kidney takes the angiotensinogen and converts it into angiotensin 1 in the plasma. So they both are swimming in our blood. They both are having fun in the blood, and then renin comes in and cuts the angiotensin to convert it into angiotensin 1. Now angiotensin 1, I have made that here. Angiotensin 1 is also now running around in the plasma. When it reaches our lungs, lungs have on the blood, in the blood vessels of the lung, facing the blood side, the endothelial cells have ACE1 enzyme fixed on them. So when angiotensin 1 comes in contact with the ACE1 enzymes, blue pill, yes. Yeah, they both are swimming in there. They both are having fun. And then one of them bites the other one and cuts it. So that's not nice of that, but that's what happens. So we'll talk about the clotting in a day. Tomorrow we'll talk about hypertension. Day after we'll talk about hypercoagulability. So here in the lung, in the blood vessel of the lung, the cell that is endothelial cell, which is facing the blood, that endothelial cell is expressing, that is how we say it, it expresses ACE1. ACE1 is like another scissor which takes up angiotensin 1 and cuts it into angiotensin 2. This angiotensin 2 is an active substance and it does many functions, and the important function for us to note at this time is it's a potent vasoconstrictor. So it increases the blood pressure and causes vasoconstrictor. And this is what we all in medicine kind of know this very well. And that is why people keep challenging me and say, hey, why do you say ACE2 causes vasodilatation? This is ACE1 pathway which causes vasoconstriction. Now let's look at this. ACE2 are also present, as I said before, in lungs, heart, intestine, kidney, blood vessels, and many other places. But these are the primary places. ACE2 are also present on endothelium. They are also present on epithelium. That is why the SARS-CoV-2 can bind with them in a respiratory system and get into our cells. So they are present in all those cells that are becoming their target of the coronavirus. So ACE2, so now please pay attention, it can pick up angiotensin 1 and convert it into another molecule set that is called angiotensin 1 to 7. ACE2 can actually pick up angiotensin 2 and convert that into angiotensin 1 to 7 as well. Now this angiotensin 1 to 7 is anti-inflammatory and it is a vasodilator and it is anti-apoptosis. Apoptosis means killing of the cell by suicide. So it stops the cell from dying by suicide. So this is the basic function. I hope it makes sense. I would just put this one back up here in front of us to say that these are the mechanisms that cause the damage. Irregularity of ACE1 and ACE2, ACE2's presence in the heart, the indirect damage to the heart because of the lack of oxygen, because of the lung injury, antiviral drugs. And the reason that people with the cardiac issues get more in trouble is, one, if they are a patient of cardiac insufficiency, their cardiac insufficiency exaggerates tremendously because the virus makes them sick, their heart sick, plus there is less oxygen. Then if they are a patient of acute coronary syndrome, then they would have increased ischemia, again because of lack of oxygen and because of damage to the heart, which would precipitate heart failure. In the old age, immune system also doesn't work very well, so we cannot control the infection very nicely, and that also causes cytokine storm. Cytokines themselves cause burden on the heart by causing vasodilatation, increased permeability, which causes reduced blood pressure and blood volume, which causes burden on the heart to say, hey heart, work more, and heart starts failing. And finally, antiviral drugs, when they are given, they themselves can cause, they are cardiotoxic, they can be cardiotoxic, and they can cause cardiac arrhythmias, cardiac failure, and cardiac abnormalities. So I will stop here. Thank you very much for your time. I think it was a little bit longer discussion, but it was important for us to understand because this is the highest comorbidity, this is the highest cause of death with the SARS-CoV-2. Yes, we have discussed the NK cells in a previous discussion. So guys, any questions before we break? Yeah. Thank you, Kelly. Since he asked about nitrogen bands, I think it's decompression. Okay. ACE2 high expression is anti-inflammatory, then will it prevent cytokine? That's what they think, Sandhya. They think that when ACE2 are expressed more in number, that helps keep the cytokine storm in check. And those patients who do not have the right number of ACE2 may have a cytokine storm created easily. Very good explanation about Renin-Angiotensin system. Thank you very much. I reduced a number of things, for example, its effects on aldosterone and other tissues. I just wanted to stay with the vasoconstrictor. Okay, if you could summarize this either today or tomorrow, especially the ACE part. Watch the video again. It will be totally fine. Greeting from Switzerland. How is the link to a 3-year-old? So 3 years old, I have done a discussion that why are patient asymptomatic. In that discussion, we talked about the young children as well. Young children have more NK cells. They have better response to the virus because they are supposed to have more ACE2 receptors. There is a study, only one study done, and that came back and they said it is not correct that there are more ACE2 receptors in the children. But in the literature, it is said that children have more ACE2 receptors because of that. One, they have more NK cells. Secondly, they have more ACE2 receptors. Thirdly, because they continue to become sick with normal respiratory infections, they have better innate immunity and they have better trained immunity. I did that discussion in asymptomatic patients. Because of that, children can handle this infection better. So hopefully that answers your question. If ACE1 inhibitor is not used, then what will be the status of ACE2? So they say, so see, there are two theories about it. I've done a separate discussion about this one. Some studies say that when ACE1 inhibitor is not used, ACE2 upregulation goes down. Other studies says it doesn't happen. And so there is a dilemma there. Because of that, American College of Cardiology simply says, don't change the medication. If you're using ASI, continue to use it. There is not enough data to say this causes damage. These are just theories at this time. I would like to ask about GS6 protein and changing macrophages from inflammation. I would love that. So that is one of the things that we should be able to look at, that what are the possible signaling mechanisms that can allow our innate system, especially macrophage, neutrophil, and NK, to become strong, which would then cause the virus to fight with these cells before it can actually replicate in a bigger number. Meanwhile, our adaptive system will become ready and kill the virus. So I know about the smoking. I will have to do some research to figure out why they're saying that. I can't talk about it at this moment. Angiotensin receptor blocker blocks angiotensin ACE1 enzyme. It does not block ACE2. Cool. So guys, thank you very much. It is 6:50. You have been with me for 50 minutes. Thank you very much for your time. Please, my request every day is the same. Please share this. So there are about 1,000 people right now who are watching on 3 channels. Please share it. That is your support for me. Thank you very much. If you don't like it, then don't share it. But if you liked it, please share it. I would be grateful for that. Thank you and see you tomorrow.